Bismillahirrahmanirrahim. Quote of the day: a positive mindset is one of the attributes of successful people. Today, the topic of my presentation is intranatal care, essential and comprehensive emergency ops and neonatal care. Learning outline of my presentation is introduction, objectives, intranatal care, essential comprehensive emergency ops and neonatal care, recent updates, and at the end, there is an MCQ session. At the end of this presentation, my colleagues would be able to describe intranatal care and also basic and comprehensive emergency obstetric and neonatal care. Introduction. Mothers and children both are vulnerable group of community. Women in childbearing age constitute about 22% of the population of Pakistan. Children, on the other hand, constitute 40 to 45% of the population of developing countries. This group is characterized by high morbidity and mortality rates. There are four divisions in the maternal health care: preconceptional care, antenatal care, intranatal care, and postnatal care. And today we discuss about the intranatal care. Childbirth is a normal physiological process, but complication may arise. Septicemia may arise from unskilled and septic manipulation, and tetanus neonatorium from the use of unsterile instrument. The major emphasis is on the cleanliness. It entails clean hand, fingernails, a clean surface for delivery, clean cutting and care of the cord, and keeping birth canal clean by avoiding harmful practices. So basically there are 5 C's: clean hands, clean surface, clean cutting, care of the cord, and canal clean. Hospital and health centers should be equipped for delivery with midwifery kits, a regular supply of sterile gloves and wraps, towels, cleaning materials, soap, and antiseptic solution, as well as equipment for sterilizing instrument and supplies. There are many aims which we achieved by practicing a good intranatal care through asepsis, delivery with minimum injury to the infant and mother, readiness to deal with complications such as prolonged labor, antepartum hemorrhage, convulsion, malpresentation, prolapse of the cord, care of baby at delivery, resuscitation, care of the cord, and care of the eyes of neonate. This is basically a method, a graphical record of the observation made of a woman in a labor for progress of labor and salient condition of the mother and fetus. It was developed and extensively tested by the WHO. What are the objectives that we achieved by a good intranatal care? Early detection of abnormal progress of labor, prevention of prolonged labor, recognize fellow pelvic disproportionate long before obstructed labor, assist in early decision on transfer, augmentation, or termination of labor, increase the quality and regularity of all observation of mother and fetus, early recognition of maternal or fetal problems. There are 2 types of deliveries in our setup: domiciliary and institutional. In domiciliary, environment must be safe, mothers healthy, pregnancy normal, and delivery is conducted at home by a trained DICE or a health wife. This is called a domiciliary midwifery. And the advantages are familiar surroundings for mother, removes fear and anxiety associated with delivery in hospital, less chance for cross infection, mother can keep on eyes on home affairs, children, and husband. And in the institutional care, about 1% of deliveries tend to be abnormal and 4% difficult, requiring the services of a doctor. Rooming in, this phenomena, keeping the baby cribs by the side of the mother bed, is called rooming in. Mothers interested in breastfeeding usually find there is a better chance for success with rooming in. It also build up her self-confidence. Now we discuss emergency obstetric care. Emergency obstetric care or emergency obstetric care refers to the function necessary to save life. They are called signal function. Signal function are a representative short list of key intervention and activities that address major cause of morbidity or mortality, and there are indicative of a certain type and level of care. WHO took an initiative to reduce maternal and newborn mortality by providing greater access to maternal and neonatal care through emergency obstetric and newborn care program worldwide. This initiative is mainly focused on low and middle income countries. Emergency ops and neonatal care refers to care provided in health facilities to treat direct ops emergency that cause the vast majority of maternal death during pregnancy and delivery and during the postpartum period. What are basic emergency ops and neonatal services include administration of parenteral antibiotics to prevent puerperal infection and to treat abortion complication, administration of parenteral anticonvulsant for treatment of eclampsia and preeclampsia, administration of parenteral uterotonic drugs for postpartum hemorrhage, manual removal of placenta, assisted vaginal delivery, removal of retained product of conception, and neonatal resuscitation. To avert death and disability, we need to ensure that women have access to emergency obstetric care. So there are 6 process indicators that tells us that how the facilities of emergency ops care are provided, how they are utilized, and how we assess the qualities of these services. Indicator 1, for every 50,000 population, there should be at least 1 comprehensive emergency ops care facility and 4 basic emergency ops care facilities. Geographical distribution of emergency ops facilities should be well distributed and it almost serve around 50,000 people. At least 15% of all birth in the community should take place in EMOC facilities. Meet need for at least 100% of women estimated to have obstetric complications should be treated in EMOC facilities. And the percentage of a cesarean section in all the health facilities where the EMOC services are available, it should be minimum 5%, the ratio of C-section, and the maximum ratio should be 15%. And the case fatality rate in the facilities, proportion of a woman with obstetric complication admitted to a facility who die, maximum acceptable level should be 1%. These all are the 6 emergency ops care process indicators. For every 50,000 population, there should be at least comprehensive EMOC facilities. Geographical distribution is very well. Proportion of all birth in EMOC facilities, at least 15% of all birth in community should take place in EMOC facilities. 100% of women have availed these facilities, and the ratio of C-section is minimum 5% and maximum it should be 15%. And proportion of a woman with OBS complication admitted to a facility, the maximum acceptable level is 1%. If we calculate all these 6 indicators, they give us the indication of whether the problem lies and where the action is needed. All these indicators are sensitive to change within months. You can know if your project is making a difference. Do you have enough qualified staff? Do you need to train staff on the management of emergency ops complication? Does hospital management need improvement? What is the supply situation like? What is the equipment? Does indicator 6 show that more than 1% of women treated for ops complication are dying at your EMOC facilities? If you check the qualities of emergency ops care, then find out if your EMOC facilities are really functioning. Check staff numbers, skill management, capacity, supplies, and equipment. Lobby your health ministry for more support and get the community to lobby with you. There are three delays model in intranatal care. Delay in seeking appropriate medical help for an obstetric emergency. A reason for cost, lack of recognition of an emergency, poor education, lack of access to information, and gender inequality. Delay in reaching an appropriate facility for reason of distance, underdeveloped transportation, medical and health infrastructure. Delay in receiving adequate care when a facility is reached because there are shortage of staff, electricity, water, medical supplies are not available, and maybe the medical supplies are inadequate. Any country can avert the maternal death and disability if it makes good emergency ops care, and it should be available and accessible on time. Uh, there are different person involved in the good emergency ops care, and they are community health workers, lady health visitor, midwives, trained birth attendants in the emergency ops care. Uh, so now we discuss the role of all these members one by one. Community health worker perform a wide range of vital healthcare roles in their communities. They serve as counselor, helping poor patients overcome the barrier that prevent them from seeking vital healthcare. Patient barriers to care include transportation, lack of awareness, fear and healthcare cost, involved in awareness campaign, proper education of a patient and nutrition. What is the role of a lady health worker? Lady health workers serve the whole community, but they play a particular important role in MCH in rural and urban slum communities by coordinating effort with traditional birth attendant and midwives, and by ensuring that all mothers and children receive adequate care. Usually belong to same community, have home in that particular locality, and their house is declared as health house with first aid kits and basic contraceptive pills, have data of families involved in door-to-door campaign. Lady health visitors, they are appointed in BHUs and rural health center, conduct institutional deliveries. In serious condition, they can refer the patient. In pursuance of her duties, she prepared her program of static and domiciliary activities, including home visiting in the villages falling in her area for at least once a week. She would have necessarily visited each village once a month. Midwives. A midwife is a trained health professional who helps healthy women during labor, delivery, and after the birth of their babies. Midwives may deliver babies at birthing centers or at home, but most can also deliver baby at a hospital. Women who choose them have had no complication during their pregnancy. Approved full-time midwifery degree course lasts for 3 years, half your time is spent studying at university and half gaining practical supervised experience in a range of setting. Uh, roles provide family planning and preconception care, do prenatal exam and order test, watch your physical and physiological well-being, uh, make your birth plan, advise you about diet, exercise, medicine, and staying healthy, educate and counsel you about pregnancy, childbirth, and newborn care, provide you with emotional and practical support during labor, deliver your baby, make referrals to doctor when needed. Now comes the trained birth assistant. The DAI or trained birth attendant remain the primary healthcare provider during pregnancy and childbirth in much of rural areas. Typically, an older or widow woman that dies draw upon year of experience and generation of traditional knowledge for her delivery practice. Six main role of traditional birth attendant on maternal health care in rural areas were identified in this study. Traditional birth attendant conduct deliveries at home. They provide health education to women on nutrition during pregnancy and lactation. They arrange means of transport and accompany women in labor. Now it's come the skilled birth attendants. Licensed and trained birth attendants are trained by the government regarding the 5 C's of childbirth: referral of a serious patient, early decision making in case of prolonged labor, proper packing skill in case of hemorrhage. Certification is given to them after proper training, and then the traditional birth attendants are called skilled birth attendants. Now it's time for the recent updates. There are different setting standards for emergency ops and newborn care. Basic emergency ops and newborn care is critical to reducing maternal and neonatal death. This care, which can be provided with skilled staff in health center, large or small, including the capabilities for administering antibiotics, uterotonic drugs, and anticonvulsant, manual removal of placenta, removal of retained product following miscarriage or abortion, assisted vaginal delivery, preferably with vacuum extractor, basic neonatal resuscitation care, comprehensive emergency ops and newborn care, typically delivered in hospital, include all the basic function, performing C-section, safe blood transfusion, provision of care to sick and low birth weight, including a resuscitation. This is the diagrammatic representation of the WHO intrapartum care model, and it includes respectful labor and childbirth care, emotional support for a companion of choice, effective communication by staff, pain relief strategies, regular labor monitoring, documentation of events, audit and feedback, oral fluid and food intake, mobility in labor and birth, position of a choice, pre-established referral plan, and continuity of the care of woman and child. This is one of the article which is related to the signal function for emergency ops care as an intervention for reducing maternal mortality. And the main findings which are discussed in these articles are: maternal mortality is a global health burden and affects women of reproductive age. It is most acute in developing countries where complications related to pregnancy and childbirth are among the leading cause of severe disability, mortality, and morbidity of a woman, with a report of 358,000 maternal deaths occurring in sub-Saharan Africa. Global health experts have identified signal function for emergency obstetric and newborn care as the most effective medical intervention for managing direct maternal complication and improving maternal survival. With the federal and provincial government want to reduce the maternal mortality ratio by 2030. It currently stands at 186 deaths per thousand, according to a Pakistan maternal mortality survey. Pakistan remains one of the country in South Asia with highest MMR, and there is a need of providing skilled birth attendant and emergency ops and newborn care are two major strategies which can help to reduce the maternal and neonatal mortality and morbidity. The availability of skilled provider trained to deal with life-threatening ops complication coupled with an enabling environment consisting of essential equipments, drug and other supply is crucial to the prevention of maternal and perinatal deaths. This is one of the study which is conducted in rural Pakistan, and barriers for the implementation in emergency ops and neonatal care is discussed in this study. The result indicates that the lack of teamwork, conflict management, communication, and improper power distribution are important interpersonal barriers. The significant organizational level barrier include job insecurity, lack of organizational culture, human resource development issue, and lack of role clarity. Lack of target management, lack of resource availability, house job requirement, and dual practices issue. were identified as a major system level barrier in this study. Now it's time for the multiple choice question. In developing countries, maternal, neonatal, and child health care are not meet the standards. Which common problem of reproductive age group of female mostly facing in Pakistan? Malnutrition, unplanned pregnancy, unsafe abortion, pregnancy-related complication, STDs. B, unplanned pregnancy is the right option. After delivery, it is recommended that the baby's crib is placing by the side of the mother's bed. This is called rooming
A,
in.
roaming in.
G, A, rooming in
A,
is the right.
roaming in.
Rooming in is the right answer. Recently introduced component of reproductive health care is care of newborn, management of infertility, management of abortion, management of STDs, prevention and control of reproductive tract infection. C is the right option,
C.
management of abortion.
C.
If you check the quality of emergency ops care, what should be the acceptable level of case fatality rate? 1%, 5%, 10%, 11%, or 15%? Quality of emergency ops care. A, 1% is the
A, 1%. 1%.
G, right answer. Assessment of women health in a community should be done by total number of deaths related to pregnancy, total maternal death, maternal mortality ratio, maternal mortality rate, direct and indirect ops morbidity. How we assess the women health in a community? C,
C.
MMR.
C.
Right answer, C, MMR. One of the major direct cause of maternal mortality in Pakistan is eclampsia and preeclampsia, hemorrhage, sepsis, abortion, ruptured uterus.
B, hemorrhage.
Right answer, B, hemorrhages. In Pakistan, maximum maternal mortality is associated with following risk factor: age of mother less than 18 years, primigravida, grand multivara, poor previous pregnancy outcome, delayed referral.
E, delayed referral.
Right answer, E, delay referral. During puerperium, most difficult complication to manage is puerperal sepsis, postpartum hemorrhage, rupture of uterus, genital fistulas, puerperal psychosis.
B, postpartum hemorrhage.
Right answer, B, postpartum hemorrhage. Government of Pakistan permits termination of pregnancy in case of rape, anxiety, neurosis, tuberculosis, eclampsia, unplanned pregnancy.
A.
B, anxiety, neurosis is the right answer. Emergency ops care, there is a 6-process indicator. What should be the maximum percentage of C-section in any facility center if you label as adequate emergency ops care? 10%, 15%, 20%, 30%, 25%.
B.
B, 15%. Maximum 15% and minimum should be 5%. This is the key of my MCQs, and thank you.